everybody, and welcome back to our Module 6 scenarios. This is going to be Module 8. Here with me today, as always, is Nicholas Gonzalez, our math guru, and our own professor, Dr. Abel. Welcome. And
Special
I'm
guest.
host, Janine, as usual. Guys, we have made it this far, but let us all warn you, this will be the most complicated scenario you've probably ever done. So, with that, let's just get the show rolling, shall we?
Yes.
So today we're going to be talking about the nutrition management of a complicated infant. Remember last week we did a non-complicated. So things, needless to say, are going to get very complex, right, Dr. Abel?
They really are. And unfortunately, some of these little tiny babies, when we can't advance and get them to full feeds, we find out all kinds of things that become complicated, like cholestasis, essential fatty acid. So you're going to learn a lot in this module.
And I think this slide is one that we have all been traumatized from our biochem and advanced nutrition and any other classes in M&T, advanced. So, but remember that these are slides from our Module 8 PowerPoint that Dr. Abel has provided in Canvas. But we briefly want to mention that these are going to be very imperative for you to reference, memorize, and, just kind of look back at and make sure that you understand, especially right now, because I know, Dr. Abel, you have highlighted the stomach, correct?
Well, actually, when an infant does develop neck, sometimes they have to do surgery and they remove part of the small intestine. So also when they might have short gut as well. And so it's important that you understand just what part of the stomach has been removed, because that is going to affect your nutrition recommendations. And even just on a side note, I personally have had two bowel obstructions. I almost died with one of them, and I have part of my ileum missing. And if you see on this slide, ileum is very important vitamin B12, and so I have to take weekly shots of vitamin B12. And I actually became very symptomatic and was the one that diagnosed myself when I went to a physician. So if you can train yourself in understanding this, it is very important with GI issues and complications like in this case scenario.
I know that the ileum is where the vitamin B12 connects with the intrinsic factor, and that's what is needed to be absorbed, correct?
Yes, that's and very important. But even like if the duodenum or the stomach, and then look, that's where the iron is being absorbed. So if you have part of that missing, you're going to need to understand that iron is going to be very important, and that there might be problems with the actual absorption. So sometimes we have to look at how we're going to infuse those infants with either iron or whatever. So yes, very, very important. And look, vitamin K is absorbed in the large intestine. So all of the things you have been learning over the years are going to come together in this scenario. And you're going to feel like Einstein. Okay, so before we get started, I just want you to realize there is a presentation in this module that is very important. It is entitled Nutrition Management of the Complicated Preterm Infant Neck. And in that presentation are some key slides that are going to be pertinent as you start to work through this scenario. So on this slide, it's basically the requirements for parental nutrition. These are the broader requirements, but of course you can go back to Ziegler's recommendation and get more specific based on the size of the baby. So looking at just the nutritional goals for both the term and the preterm, and the amount of protein that is what we call normative data, and then just looking at things like how we'll monitor for growth. That is absolutely important. And with parental nutrition, this will be the first time that I'm going to now introduce the electrolytes and the trace metals, selenium, copper, zinc, manganese, and chromium. And you as a dietitian will be making those recommendations as well as the macronutrients, specific recommendations, not general broad ones. So on this slide from the same presentation are the electrolytes and the minerals. So these are the recommended amount and what we are looking for when we start to make recommendations for parental nutrition. So this slide is going to be very important as we walk through this scenario. Okay, go ahead to the next one. Mm-hmm. And then these are the recommendations for parental nutrition. Very important that we get a daily BMP and look at electrolytes and renal functions are stable twice weekly, things like magnesium, phosphorus, and triglycerides. So these are going to become part of your monitoring and evaluations in infants like this. And then, of course, we're going to follow weights daily and OFCs and lengths weekly. And then we're going to, if the infant remains on PN for less than 3 weeks, we're going to obtain a weekly direct bilirubin. And that is to screen for cholestasis. Very, very important. So this slide again will be very important for your ADINE note.
So if the infant is on PN for more than 3 weeks, then this is where the direct bilirubin definitely comes into place because
absolutely, because most babies we do become very concerned with cholestasis because of being on parental nutrition, and that is a direct result of usually the type of lipid. We're actually seeing more with the omega-vins and the omega-3 being used as a lipid, and so we're seeing less of cholestasis with that in mind. But that's a whole evolution that we don't have time to talk about right now, but very fascinating when we talk about parental nutrition.
Yeah, definitely.
So on this slide, this really can give you more what you need to know about trace metals and its guidelines. And so I'm not going to read that to you because we have so much information to cover. But again, this is the guidelines that you're going to be incorporating in your answers throughout this scenario and with your ADINE note. Okay, you want to go to the next one? Yeah. And then this is the recommendations for both the preterm and the term infant in the parental nutrition. So you can see that zinc and selenium right from day 1 are 400 mics and 3 mics of selenium. And then it shows you the carnitine. And then after day 14 of being on parental nutrition, it talks about copper. And we don't recommend the chromium and manganese because they are contaminants and are a concern as well. And then this slide is extremely important. This slide will help you understand the advancement schedule for enteral nutrition. These little babies are very different than that healthy preterm. Last week you learned advancement should be about 20 mils per kilo, and that's what we normally do, but not with these babies. We are so afraid of the feeding intolerance and just the issues. So we advance very, very small. So you have 3 options. You could do 10 mils per kilo every other day or up to twice a week, or you could do 1 mil per hour twice a week, or a half a mil every hour every other day. This is extremely slow in our advancement. We're looking for ostomy output and toleration because if these babies actually stool out, sometimes even we might have to stop enteral nutrition completely and go back to parental nutrition, which is, again, very complicated for infections, sepsis, cholestasis, and often these kids just don't grow well on parental nutrition. Even before we got started, Janine and I and Nicholas were talking, and Janine made a very good point. You know, when we have a diet, we have different types of fats in our diet. But when you're on parental nutrition, you're very limited to the amino acids and the lipids and, of course, the dextrose. So this is a very important slide to understand. And then the other thing that you're going to learn this week is ostomy output. So that is where, just like in an adult, they have a bag and they stool out into the bag. And so our goal is to keep it under 40 to 50 mils per kilo. And, you know, we're really concerned if the ostomy output doubles in volume. And so that is our job. And we're going to look at fiber. We can actually pectin, which is, you know, if any of you have ever done canning, you literally buy Certo that has pectin in it. And that's actually what we give sometimes with these babies to help control the ostomy output as well. And that's, but anyways, the ostomy output is going to be critical in determining whether the baby is tolerating the enteral nutrition that we are providing.
So now we're going to move on to Bradley's scenario, the specific scenario. So he is a former preterm infant who developed NEC in the NICU, which, as we learned, probably in like one of the earlier scenarios, that's necrotizing enterocolitis, and it is rather common. Is that right, Dr. Abel?
It can be definitely, unfortunately, yes.
Right. So here we have just the date of birth of the infant, the gestational age, and the birth weight. And on the right here is a chart that you're going to be filling out in your own scenario, which is a little different from this one specifically. But it just goes over the percentiles, the z-scores, the postmenstrual age, which we've talked about several times over the course of these scenarios. So we're not going to go into how to do it specifically, but you do want to take a note of percentiles and these z-scores and where this infant, Bradley here, is landing on the growth charts. So if we take a look at the percentiles and z-scores, we see that over the course of a week, from May 22nd to May 29th, the percentile is not changing very much, even especially in length, he's actually decreased in length from the 47th to the 4th percentile. Same with the head circumference. So, and the rate of weight gain also at 6.5 grams per kilogram per day is also very low. So right off the bat, we do see some key factors to take into consideration that might be worrisome. So we're going to take a look a little bit more at his medical history. And then we're going to look at some growth charts just to see how he's plotting based off of this data.
So this is an actually real scenario that I just recorded the information, changed his name, but the rest of the information is the same.
So here we have Bradley's scenario. As we just mentioned, Bradley was a former preterm infant that presented with NEC in the NICU. So let's go over his medical history. On March 13th, remember he was born February 19th. So on March 13th is when he had the partial resection, 80% of the ileum and the jejunum, including the ileocecal valve. And he also had a partial colectomy, meaning part of the colon was also removed. On May 3rd, he had the ostomy takedown. So remember that the ostomy is the stool bag. And so that was taken down, and the G2 placement was placed to see if Brandon could start to see that reconnection between the small intestine and the large intestine. So we can hopefully try to get that reconnected and get the gastrointestinal tract functioning. Correct, Dr. Abel?
Mm-hmm. Yes. And it's also important to note what was the final bowel length.
Yes.
And you could go back and look at the presentation, and feel free to email me questions.
Of course. So we had the final bowel length of 54.5 centimeters. It's not mentioned here in this slide, but this baby, Brandon, did present with cholestasis. So we practiced a lipid minimization strategy, meaning that we tried to reduce the lipids to try and help reduce the incidence of the cholestasis, but it failed. So in that case, we started the SMOF lipids, and SMOF lipids is what we also have on that presentation, where it is a soybean, MCT, olive oil, and fish oil lipid emulsion that's used with these babies who normally present with cholestasis, and it's been proven to be effective in reducing the incidence of cholestasis in premature babies. And then he is status post a Broviac placement. So this is something that the premature babies who have been on parenteral nutrition for so long that they have obviously not been able to be taken off of parenteral nutrition. But I mean, think about it, right, Dr. Abel? He's been in the hospital since February. It's now May. It's been over 3 months, and he's still on PN. So this baby has to be sent home on PN, correct?
More than likely, he will be. They're thinking about that, yes.
So they're just kind of preparing for that with the Broviac placement. So again, guys, this is a very, very serious situation with this poor baby, you know. So it's very important to know the medical history and use that in your scenario to, again, make your recommendations and make your interventions.
On these next couple slides, and Janine's probably going to go over them, but I just want to say, again, this was a real baby, and these are the real growth parameters of this baby. And you can actually see like where it spikes here. He probably became very edematous, and that's when we first saw that he had neck. So if you look at the slides about neck, you see those large tummies, and then you can, so, you know, and then you can see where he was growing along. And again, we see another spike here. And then we see really where he is starting to fall back down on the actual growth of this child. And this is the length. And length is actually, if it's done correctly, is a better indicator of stunting, especially the internal organs. So you can see that he really, at the time that he got neck, look at what's happening with the length. It's definitely going way down to the second percentile. This is a huge concern for us and for this baby. So these are important. And really, a lot of dietitians today, because of like PediaTools, they just look at one moment in time. And I would really caution you to do that, because these babies, you really need to look at the whole picture of how they are growing in the length, OFC, and the weight, so that you know, we do numbers with growth velocity, but having the visual of how the baby, you could actually, when you get very good at critically thinking and assessing, you can almost look at these charts and know, without looking at the medical records, what's going on with these babies.
I'm sure you're at that point, aren't you, Dr. Abel?
Yeah. And look at, again, at the head, what's going on here, how it's falling off. So remember, with malnutrition, weight is the first parameter that crosses percentiles, then length, and then head. And so head is where our cognition and brain and very, very important. So this is a huge concern when we're looking at malnutrition and what's actually going on. Even if we went back and looked at the weight slides, the weight looked kind of like, oh, everything's okay. But again, those babies become very edematous, and it's very deceiving when we look at just rate of weight gain.
So now labs.
So on this scenario, you're going to actually be writing a note for April 29th and then a note for May 29th. And these are the labs, and the L's mean low and the H mean high. So again, you want to refer back to that presentation and really start to get a feel just how this might alter your decision of what you're going to write in the PN script. So in the PN scripts, we don't write ranges. We actually are going to write real numbers down for our recommendations.
So we're going to be deciding the actual amount. And
you and Nicholas are going to decide. So let's see how you do.
Here we know copper improved, zinc normal, chromium is high, but we are not doing any chromium or.
Yes, that's correct. Yes.
No.
So based off of this, just looking at, you know, let's start from the top. We can look at copper. So it was low in the beginning. Now we're getting kind of normalized. So we're getting kind of normalized within that range, but we are still towards a lower threshold. And because of that, and because of the general tendency of infants to grow kind of quickly, even though the growth is a little iffy here, but even then, like since we are in the lower threshold, I would say that we should probably recommend an increase in copper supplementation just to kind of push that more to normal values here.
Yeah, like maybe like 0.5 micrograms or something. And then chromium, I wouldn't. Obviously, that's high. And
right.
Zinc and manganese are normal, and then selenium is definitely low. So I would definitely also recommend a selenium supplement. Because it's at 41. So maybe like.
So yeah, I mean, we don't have like the exact how much selenium, for example, that this infant is intaking at the moment, but we would kind of recommend for an increase of selenium from about 3 to 4 micrograms per kilogram per day. And for the copper, like we mentioned, we should probably increase that too. That'd be about 25 micrograms per kilogram per day. So we would probably increase by about those ranges, and then continue to monitor monthly or weekly, whenever this infant is there.
So again, I just want to encourage you to go back to the presentation and look at what is recommended to where to start. Like how much do we usually start with copper and zinc? We usually don't add chromium, just like Janine said, and the manganese, but selenium. So the zinc, we usually start with 400 mics, and the selenium, we start with 3 mics. And you could really go up to 4 mics. That's kind of what we can do. Okay. And the copper, we start with 20 micrograms per kilo per day. And you can, like Nicholas said, you can increase by 5, so you could go to 25 mics. But that PowerPoint will really help you with this.
Do you remember which PowerPoint it was? Which module?
It's in this module, and It's called the Nutrition Management of the Complicated Preterm Infant, and it has NEC underneath it.
Okay, so there you go.
And I have it in with the case scenario and in the presentation.
Got it.
So can you go back just one second?
Of course.
So on April 29th, you're going to actually make recommendations based on these labs. You're going to just write, that'll be like the upcoming question. And then I think you're going to be asked to make recommendations then on May 29th. So you're going to kind of make 2 different recommendations based off of these labs.
Got it.
And that's what we do in the NICU. We are constantly assessing these little ones.
Okay, so now we have our essential fatty acids. So these should not be new to you. These were discussed in our advanced nutrition class. Remember that the triene tetraene ratio and the meat acid are what's indicative of the essential fatty acid status. So if we can see here, we'll see on May 9th that we had a high ratio of the TTR and also with the meat acid. So this is most likely when Brandon presented with the cholestasis. And now we're at May 29th and they have normalized. But it's this is just to show you how important it is to monitor these labs in particular to make sure that they're not at risk for cholestasis. And then, right, Dr. I just know just from my research, because I read so much about the essential fatty acids and parenteral nutrition, it's such a high risk.
Yeah. Yes. And then with cholestasis, we lower the lipids, and then these infants usually do become essential fatty acid deficient. And that's why we check for these things. And then we make recommendations. The dietitians, they're looking to you to make these particular recommendations. And again, I want to encourage you, if you don't remember from advance, There is an article, it's called Interpretive Guide for Fatty Acids. And if you go in that guide and look up both the meat acid and the tyrine tetrine ratio, it will help you. It's just a little paragraph, but it will help you hopefully understand this as well.
More labs. Okay, so here we have this. Would this be in the BMP, Dr. Abel?
Yes, it would be.
Okay. So
The direct bili, the INR, and the urine sodium, no, but the first three, yes.
yes. Okay, so we have the sodium and BUN. We have phosphorus that was low on May 21st, and by May 28th.
So why do you think we're concerned about the phosphorus? What part of the body are we concerned with?
Well, phosphorus
Probably the
is
kidneys.
electrolytes. So
Yeah, that too, but bones, your bones as well.
calcium and phosphorus.
Yeah.
So so the fact that he was low would be indicative of some type of bone malnourishment?
Well, not necessarily, but we would be concerned because this baby was on parental nutrition and we just couldn't get adequate phosphorus. So if we lose the central line and we have to go to a peripheral line, we can't add so much calcium and phosphorus because of complications. So being on parental nutrition really adds to complications, and phosphorus is very hard to actually get to the level that we need to be adequate for the infant. So it's not unusual for an infant that's been on parental nutrition for a long amount of time that we see low levels of phosphorus. So your recommendation would be phosphorus. And again, if you went back to that slides, it'll help you know how much phosphorus to add.
So it's okay, it's safe to add a supplement of phosphorus
into the parental nutrition, correct?
Even if it's the peripheral, not the central.
Well, yeah, that's a whole other conversation for another time.
Okay.
But, yeah, there's more caution, and what we can add is more limited, because the peripheral line just simply means you're going through a much smaller vein. It's on the outside. The central lines are the main blood vessels that are, the arteries are much larger, and so they can handle the larger components that we're adding to the parental nutrition.
Do we know if Brandon was on central or peripheral?
He was on a central line most of the time, but when they're on parental nutrition, your veins, just think about your veins. If you're constantly using veins, they wear out. The veins wear out with the needles being inserted into them. Think about how small this baby is, guys, and we're putting this parental nutrition into them 24 hours a day, and just the complications that are around this. So yes, infections occur. There are lots of different things that might cause us, and so then we can't afford for this baby to go an extended period of time with no parental nutrition. So then we do a peripheral line to help hold the nutrition going into the baby, but our numbers are going to be a lot less of what we can actually get into the baby. So all of these things add to the complexity of these little tiny babies.
Wow. So also our the direct bilirubin is high from May 21st all the way up to May 28th. It only went down about 1 milligram per deciliter.
May 21st, that's extremely high and very indicative of cholestasis.
Super high.
May 21st is I believe the baby's 3 months old, so been on parental nutrition for 3 full months. Huge concern we have going on right now. So at this point, we've lowered the lipids probably all the way to 0.5, or even taken it out altogether, because we got to get the direct bili down. It's huge. And so that's where we started the SMOF, and that would be your recommendation. And we got it down to 5, which is still extremely high. You know, anything above 2 is a concern.
0.2, right?
the range is 0.0 to 0.2. I mean,
Yes,
super high.
yes,
And
exactly.
then we have our INR, which is our international normalized ratio, which is indicative of our coagulation factors. So this is normally with the PT INR, correct, Dr. Abels? What it's normally referring to?
Yes.
So this
So what vitamin are you going to be concerned about with coagulation?
coagulation, you always
Okay.
think vitamin K.
Yes.
So
very
we're
good.
definitely going to have to, think of a vitamin.
And you as the dietitian are going to recommend vitamin K when you see these numbers. This
And
is part of your job.
and basically the way that you should think about this PT-INR, it, like Janine said, it's a ratio. So it's calculated by dividing the current rate of clotting over the normal rate. So if you're taking longer to clot, let's say you take 2 seconds to clot, just as an example, and the normal rate is 1 second, that's 2/1. So it's greater than 1. So as we see in this infant here, he's at about 1.8 in May 21st, 1.48 in May 28th. So we know that that's higher than 1. That's higher than the normal clotting ratio time. So we know that he's taking longer to clot, and that's when the vitamin K would come in handy to help with that, provide those clotting factors to kind of normalize that ratio.
Mhm.
Okay, so you see on the serum sodium, they're at 135 on May 21st. That's at the lower end, and some of us might say, okay, that's normal. We're not going to worry about it. But you go down to that urine sodium, 34 is pretty low, and you definitely want to increase your sodium intake. And that's why then the urine went to normal, 115, and now they went up to 144. So we would then just maybe decrease back to a more normal amount. So again, these are very important recommendations that the team is looking to you to make.
And sodium is a very important electrolyte.
Yeah, especially it's important for electrolytes, but it's also important for growth. And sodium is easy to lose. We excrete it in the urine, which I thought, oh, this is a great way. I've been saying that in several of the modules. You can secrete it through your skin. And sometimes there's under those Billy lights. That's how we try to get the direct Billy to go down. And so they might be on a Billy light underneath them or above them. And so they can be secreting a lot of sodium even as a result of that as well.
So many things to keep in mind, guys. That's why this scenario is very complex.
Yeah. This is the their direct bilirubin numbers, and so you can see, being on parental nutrition and during the first week, no big deal, it's okay, and then kind of stabilized out, and then it really started to peak, and they're 1, 2, 3, 4, 5. So about the 5th week, it started to really become a huge problem for this baby. So again, these are real numbers. These are real pictures of the when I worked in the NICU. So,
Wow.
This is content, people. Don't take it for granted. This is real life. Okay, so now we are going to take a look at Bradley's PN order. And we're going to figure out what the volume is and the calories based off of his PN order. So again, as always, we're going to take a look at the volume first. So we're going to see that the PN order was infused at 13.7 milliliters per hour via a central line, like Dr. Abel mentioned, at based off of his current weight of 3.69 kilograms. So let's take that 13.7 milliliters per hour. And again, please work along with me. Like Janine said earlier, practice makes perfect. I'm sure your parents have told you that, your teachers. It's true. So we're going to convert this into milliliters per kilogram. So to do that, we need to figure out, how many hours is this infant's PN running. We're gonna consider it to be the full 24 hours in a day. It could be between 22 to 24, but we don't have the specific number, so we're gonna go with 24 hours here. So that's gonna give us a total of 328.8 milliliters per
Okay.
per day, right? And then we need to divide that by the infant's weight to get it in milliliters per kilogram, right?
Mhm.
So we're going to divide it by the 3.69 kilograms to give us 89 milliliters per kilogram. Okay, so that's the volume of the PN order
Per day.
per day. Practice makes perfect. So now with that, we're going to take a look at the specific macronutrients. We're going to start with amino acids, my favorite one. You already know who I'm going to. Janine, tell me what's going on here. How many calories per gram? No, amino acids, not protein.
The amino acids. Those 4 grams per 1 kcal.
Right. So like it says here, we have 2.6 grams of amino acids per kilogram.
Mhm.
And we want it in calories per kilogram. So like Janine just told me, for every gram of amino acids, we have 4 kcals. So our units here are going to cancel. 2.6 times 4 is going to give us 10.4 calories per kilogram of amino acids. Okay. Now we're going to take a look at the dextrose, which we have highlighted here on the glucose infusion rate, and we're going to write it out. So we have 6 milligrams per kilogram per minute. And again, we don't know exactly how many hours this is running, but it could be 20 hours, 22 hours, 24. Since it doesn't specify, we're going to assume it is 24 hours. And we're going to get rid of the minutes and convert that to day because we want it in kilograms per kilogram per calories per kilogram per day. So we're going to multiply this by 1440 minutes in 1 day, which will get rid of the minutes here. And 6 times 1440 is going to give us that 8,640 milligrams per kilogram per day. Now we have it in milligrams. We want it in calories. We need to convert the milligrams to grams so that we can convert the grams to calories. So to do that, we're just going to divide by...
Before we move on, though, I do want to reiterate that while we do know that 24 hours equates to 1440 minutes, remember that when you are in practice, you need to make sure that this baby is running on a 24-hour continuous cycle. That's not the case most of the time. It can be between 20, 22, 24. So remember that those minutes will be changed. You cannot rely on 1440 minutes to calculate your GIR/dextrose every single time. Make sure that you have that right, because if not, it could be life-threatening, right, Dr. Abel?
You're going to have the wrong calculations, yes. And
Yeah.
Yeah, and you don't want to get so much dextrose or and get them hyper. On top of every other thing, we don't want to become
hyperglycemic. Yeah, exactly. So remember that you don't always rely on the 1440. Just make sure that you have that. Make sure that you're calculating the hours to minutes correctly.
Mm-hmm. So like I was saying, we would divide the 8640 milligrams divided by 1,000 milligrams to convert that into grams, and that will give us we have 8.64 grams per kilogram per day. So now we are on the right track. Going back to my friend here, tell me, Janine, how many calories per gram of dextrose?
3.4.
3.4. So
you're so much more confident now than that first time we did this.
I was just like, bam.
And you all should be too. So the grams are going to cancel out here. We have 8.64 times 3.4 gives us about 29.4 calories per kilogram per day of dextrose.
Yeah, I got that.
Okay. All right. So now we're going to move on to the lipids here. Now, the lipids are a little bit different in this case because previously in the other scenarios, we've been working with the 3-in-1 formula. So in a single bag, we would have our amino acids, our dextrose, and our lipids. But in this case, it's a 2-in-1 formula. So in one single bag, we have our amino acids and dextrose, but separately, we have our lipids. So it's kind of a two-step process here. So let's work with it. So first, we have our rate again at 1.92 milliliters per hour, and we want to convert that to 2 milliliters per kilogram. All right, so we have 1.92. And again, like Janine said, we don't know exactly how many hours we're running with, but we're going to assume in this case it's 24. We want to cancel out the hours. And 1.92 times 24 is going to give us
46.08. You got it?
46.08, you said?
Yeah.
Perfect. So that is milliliters per day. But of course, like I said, we want that in milliliters per kilogram. So we are going to divide that by the kilograms of the weight of the infant in kilograms, which up here is 3.69 kilograms, which is going to give us approximately, we're just going to round here, it's approximately 12 milliliters per kilogram per day. So now we have our volume of lipids, which we're going to add together with the volume of the previous calculation in a little while. But first, let's take the grams of lipids and convert that to calories per kilogram per day. So like I mentioned on the left, we have 4.6 grams of lipids over a 12-hour hang time BID, which of course stands for 2 times a day. So that means we have 4.6 grams of lipids BID twice a day. So we're going to multiply that by 2 to give us 9.2 grams of lipids in 1 day. Okay, so now we have the grams. We want to see what that is in grams per kilogram. So we're just going to divide that by the weight of the infant of 3.69 kilograms, which will give us approximately 2.5 grams per kilogram. Okay, so, well, per day. So we are right where we want to be at. So, Janine, tell me, how many calories per gram of lipids are we going to have here?
10.
10. So we have
10
10. A little more enthusiastic, please. So we have 10 calories. Perfect. So we have 10 calories per gram of lipids. This is going to cancel here. So 2.5 times 10. I'm just going to write it over here on the left. It's going to give us 25 calories per kilogram per day of lipids. So please do it on your own because I don't have the space. But we're going to add the 89 milliliters of volume with the 12 milliliters of volume from the total volume, the dextrose and amino acid plus the lipids. And we are also going to add the calories from the amino acids, from the dextrose, and from the lipids here all together to use in this next slide here.
Got it.
You're also going to report the amino acids as well. And that one's easy. So you'll bring down the 2.6 grams per kilogram.
Mm-hmm.
Right. Okay. Wonderful. So with all that addition going on there, what are we going to have here? Our volume is going to be 101 milliliters per kilogram per day. Our energy is more or less, it's approximately 65 calories per kilogram per day. And lastly, our protein, like Dr. Abel said, just bring it right on down. We have 2.6 grams of amino acids per kilogram per day.
And Nick, can I just say something 2 seconds?
Please.
It's really important that you do not round till you get to the very end. And then the volume, we round to whole numbers. If it's 0.50 and above, we round up. If it's 0.49 and lower, we round down. And the same with calories, it's a whole number. Protein and iron, we go to 1 decimal, and all the other electrolytes, we do a whole number. So that's very important. But please don't round until the very end, especially in the parental nutrition. Because even a 0.1 or a 0.2 can make a huge difference with your answer.
That's really great advice.
Good point.
Yeah. All right, so let's calculate this enteral nutrition order now.
Yeah, let's do it. So let's take a look at the prescription really quickly. So we see 20 calories per ounce of progestamil at 4.5 milliliters per hour. Now I just want to focus on the specific formula of progestamil for just a second. This is an extensively hydrolyzed formula, which means that the proteins within the formula are mostly broken down, which helps with absorption, because since this infant is having some GI issues, he would have trouble breaking down whole proteins on his own. So providing this formula really helps with that digestion, so that he needs to do less of that work on his own, right? So let's take a look at the volume first. We have it in milliliters per hour, but like always, we want it in milliliters per kilogram per day. So the first one we're going to do, like we've talked about already, we're going to assume it's 24 hours. It's not always the case, but let's just assume it in this case because it doesn't specify. So we're going to multiply that by the 24 hours in a day, which would give us approximately 108 milliliters per day. And that's great, but we want it in milliliters per kilogram per day. So the per kilogram is just to divide by the weight of the infant, which, looking back at the previous slide, was 3.69 kilograms. So with this, we see that this infant is on a volume of 29 milliliters per kilogram per day of progestamil, this enteral nutrition formula. Okay, so now that we calculated that volume, we want to go ahead and see how many calories the infant is getting based off of this formula. So like Janine and I have mentioned quite a few times, this calories per ounce to calories per milliliter conversion is incredibly important. So for every ounce, we have 30 milliliters. So we know that 20 calories per ounce will equate to about 0.67 calories per milliliter. And now that we have that, we can go ahead and change that to calories per kilogram per day. So all we're going to do is take that volume that we calculated, and multiply that by the 0.67 calories per milliliter. And we see that we are left with 19 calories per kilogram per day. Okay, so very simple. Last thing we're going to do is go ahead and calculate the protein. And we're going to start with what we already know, which is that the energy in this prescription is going to be 19 calories per kilogram per day. Now, we want to multiply that by the grams of protein that this formula is going to deliver. And again, we can take a look at the website for the specific formula and see that for every 100 calories, we are given 2.8 grams of protein. Right, so every 2.8 grams of protein for every 100 calories. Okay, so again, we want to end up with the grams of protein per kilogram per day. So when we cross multiply here, we see that the calories are going to cancel, and then 19 times 2.8 divided by 100 is going to give us 0.532 grams of protein per kilogram per day. So we're just going to round that out, like Dr. Abel said, always at the end here. We have 0.5 grams of protein per kilogram per day. And these are the numbers we're going to get specifically from the enteral nutrition order.
And I want to just interject one more thing. It's not on the slide, but in the actual assignment, it was just a note that sometimes you'll see in the chart, and it just said may take 10 mils BID for oral skill development. So that just means that you'll take 10 mils of the progestamil, and they can actually utilize that for stimulation and oral intake. So and usually either the PT or OT or speech might actually do that, or even the nurse. But that was just a note that was in this case, and you wouldn't need to do anything with that. We don't usually calculate that and include it because it's very minuscule.
Good to know. So let's just go ahead to the next slide, keeping these in mind. I know you all did the math with me, so you have it on your piece of paper. So here we're just going to take the total volume of the PN and the EN, because this infant is on both, and add them all together to see that final volume, energy, and protein. So of course, so 101 volume plus the 29 gives us approximately, well, exactly 130 milliliters per kilogram per day. For energy, we have 65 calories from PN plus 19 from EN for a total of 84 calories per kilogram per day. And lastly, our protein, we have 2.6 from parenteral and 0.5 from enteral for a total of 3.1 grams per kilogram per day. Okay, so these are our final values that this infant is going to be receiving based off of the two separate nutrition orders that he is on.
All right, so here we have our input and our output flow sheet. Dr. Abel had mentioned this is normally what you're going to be seeing when you're rounding, right, Dr. Abel? So this is going to be the basic information of what you're going to be measuring, which and we all should already know this from basic MNT as well, where we're measuring the input versus the output to really get a gauge as to if this premature baby is having an issue with the PN, EN, especially EN, right?
Yes.
And so this is going to be very imperative, where we're going to be assessing between the dates and between the weeks, and especially when we're looking at the stool output and the urine output is really where we're going to be able to kind of compare and contrast and see how this baby is reacting to the nutrition support.
Well, we've been learning how to do a lot of calculations, and I would imagine some of you are like over the top. I'm done with all these calculations. I remember when I first started in the NICU, I actually had to learn these on my own, and it was pretty stressful, and the person teaching me got very frustrated with me. It takes a while before the light bulb goes off, but these are real babies. These are real patients. And this information is not just for the NICU. It's transferable to pediatrics and to adults. Really learning how to calculate what's in a parental nutrition, what's in a tube feeding, and what is in oral intake is all part of the major part of the A9 note as the dietitian. That is our major assessment, is assessing actual intake and relating it in pediatrics to growth. But in the adult population, we're looking at maintenance or even possibly weight loss, depending where they're at. So this is very important. And now on this slide, you're part of a medical team. There's going to possibly be a surgeon there, a neonatologist, a PT, OT, a pharmacist. There'll be many disciplines. Sometimes you'll round together as a group and go bedside to bedside. Other times with complicated babies, you'll sit in a conference room and you'll go through maybe 10 to 18 very complicated babies and present the information. You could be doing this on a daily basis or maybe every other day. So this becomes quite the norm. You as the registered dietitian providing the data of information. So on this slide, we have the recordings from the nursing staff. They are recording what's actually being delivered to that premature baby. And so we see, if you went to the far right, that is what the baby took in on May 26th to May 27th, that full 24 hours. They weighed 3.6 kilos at that time, and they took in a volume of 327 in PN and 44.1 mils in the lipids. And the progestin, they were doing kind of pretty good. They were at 168 mils. We were so excited. And they had an oral stimulation of 10 mils, which they divided up between 2 times a day. And that oral kind of helps with stimulating the gut. It also helps sometimes rinse out the mouth. And so it's very important. And their output, the urine stool mixed, remember they had an ostomy bag, was 177. And then they actually, I'm sorry, I think they had a takedown by this time. So they, when they opened the diaper, if there was both urine and stool, we just weighed it out and had it in, measured it out in volume. And then there were actually 4 times of just stools. And then I'm not going to go over everything, but the next day, May 27th to May 28th, you see what's going on. We like to see the history of both. When we look at growth, we look at history, but we also look at intake and output over a certain amount of time, so we can really begin to grasp and understand what is happening in this vulnerable baby. And today is May 28th to May 29th. So today is May 29th. We're looking at the last 24 hours. The baby is now 3.7 kilos. And we have a volume of 327 mils for the PN. That's what was actually delivered. The lipids were 42.9. The progesterone is down to 108 mils. And we didn't give any oral, and this was the urine stool mix of 174 mils and stools of 7 times. So now what we have to do is calculate out the calories for each of these things. And so through all of the pediatric courses, I often talk about how do we go about obtaining calories when all we have is the meals. So what you need to know is cals per mil. So we determine the cals per mil in the volume of the PN, in the volume of the lipid, and hopefully you remember how to do the cals per mil in the enteral. So remember, if it was 20 cals per ounce, we are simply dividing by 30 mils per ounce, and we get 0.67. If they were at 24 cals per ounce, it would be 0.8 cals per mil. I know that Janine and Nicholas have gone over this. They've encouraged you in earlier modules to memorize this. But today, on the next slide, we're going to talk about how do you get the cals per mil in both the PN and the lipids so that we can calculate on that previous slide the calories, so we can tell the team this is the amount of calorie intake, and we're going to compare that to the normative data to see, does the growth make sense or the lack of growth? And that's going to influence then our recommendations of what we're going to do next. So feeding intolerance is very important in these premature babies. And we're at the point where we have to decide, are we going to go up on parental nutrition? Or are we going to advance on the enteral nutrition? The last thing you want is for feeding intolerance and something like NEC, and that's what this baby has. And unfortunately, some of these babies with NEC do pass away. So it is an incredibly important responsibility as we are making these kinds of decisions. And as you're hired into these positions, there is not additional training. That's why I personally spend so much time helping you learn how important, where these numbers come from, how to calculate them. And often the students that come through these courses say they shine on their internship because they can do things much quicker because they understand these calculations and how to do them and why they're doing them. So bear with this whole process and you'll be, it's kind of like when you go to the gym and you're lifting weights and then all of a sudden one day you accomplish that goal. And that's what's going to happen here. You're going to accomplish a goal that very few people can do. And that's understanding how to do calculations to be able to assess the intake of a combination of parental, enteral, and lipids in this population. So kudos to you, and if you are patient with yourself and patient in the process, you're going to win in this whole process. All right, so let's look at it. The first thing we need to figure out was the parental nutrition.
All right, so Dr. Abel mentioned just now, our goal here is to calculate the calories per milliliter for the PN solution. And it's very similar to kind of what we did with the EN, but let's go ahead and look first at the order itself. So the order from a few slides ago provided 2.6 grams per kilogram of amino acids in the 2-in-1 bag, and the GIR was 6 milligrams per kilogram per minute. And this gave us 10.4 calories per kilogram. Our GIR provided 29.4 calories per kilogram, and that gave us a total of 39.8. So that's where we're getting this number right here. Okay, so to figure out the calories per milliliter for this 2-in-1 solution, we're simply going to take that calories per kilogram and multiply it by the or divide it by the volume, but and we're looking at it in units here. But simply you can divide that calories by the volume, but we're going to multiply it by 1 over the volume, which is 1 kilogram over 89 milliliters. That way the kilograms here will cancel, and then we'll have 0.45 calories per milliliter. Okay, so that's the 2-in-1 solution that had the amino acids and the dextrose. Next, we're going to look at the lipids, which was separate. So thinking back to the previous slide, and we have that down here as well on the bottom left, we had 12 milliliters per kilogram volume of lipids, which gave us 25 calories per kilogram. So we're going to do the same process here, 25 calories per kilogram. We want to get rid of the kilograms. So for the volume, we had 12 milliliters. The kilograms will cancel, and we are left with 2.1 calories per milliliter for the lipids portion. All right, and lastly, just like Dr. Abel mentioned, for the EN, the formula itself was 20 calories per ounce. And I know you all know how to do this. It is coming back to bite you, so never forget it. It's going to be our 0.67 calories per milliliter. So just again at the goal, we were just getting the calories per kilogram and the volume and figuring out the calories per milliliter. And we're going to go ahead and use that now in the next slide. All right, now looking at this slide, the first thing we're going to do is calculate the total volume. So this chart, like Dr. Abel mentioned, we're looking here on this date, and it is what is actually delivered to the infant. So let's calculate the total volume first. So we have the 327 from PN plus the 42.9 from the SMOF lipid bag. And lastly, our EN, which is 108 milliliters, which will give us
477.9, so 478.
478 milliliters. And that's great, but as always, we want it in milliliters per kilogram. So we're going to divide that by the weight of the infant, which was 3.7 kilograms. And that will give us 129 milliliters per kilogram per day. So that is the actual delivered volume. Okay. Next, we're going to look at the energy. And to do this, we need to take each volume individually and multiply it by the calories per milliliter that we just calculated in the previous slide. So we have that up here for you in green here. Now, let's start with the PN. We're going to do the 327 milliliters of PN times the calories per milliliter plus the volume of the SMOF lipids, 42.9, times the calories per lipids, or calories per milliliter, plus finally your EN, which is 108 milliliters, again from the chart up there, times the 0.67 calories per milliliter. Okay, so the milliliters are all going to cancel out here, and we are left with a total of 309.6 calories. Okay, but again, we're not done. We want to know divided by the kilograms of the infant. So divided by that weight will give us 84 calories per kilogram per day. Perfect. Now, lastly, just the protein based off of this volume. This one just has one little additional step. here we have the actual volume being 327 delivered in PN, whereas what we calculated was 328.8. So we're going to figure out that ratio based off of the, and look at how that ratio works with the amino acids delivered in the bag. So we have 327 over 328.8 milliliters, which is
0.99.
0.99. So they received 99% of the fluids that was in the bag, times the original grams of amino acids that was in the bag, which if you just go back a few minutes, you'll see that it was 2.6 grams of amino acids. So if we multiply that out, we'll get the
Per
total
kilogram. Nick, make
per kilogram.
kilogram.
Per
Just
kilogram.
important to have those right units. Thanks.
Correct. So if we do this math, we will figure out what the total actual delivered amino acids via PN was on this day. And it just turns out that it's actually about the same if you round it out. It's still 2.6 grams of amino acids. But it's important to know how to do this because if at any point they delivered a lot less that was in the actual bag, then that number will be totally different. And the same goes for the enteral nutrition. If those numbers were any different, in this case they're not, it's still 108 milliliters, then that value would change. But since it's the same, the EN protein was 0.5 grams. So in total, the protein would be 3.1 grams per kilogram. Okay, pretty much it.
Great job.
Got it. Okay, let's do our ADIME now. So guys, remember we already went over we basically assessed all of this information. Remember to correctly fill it out in your ADIME note. Remember that this is a legal standardized document that registered dietitians use in clinical practice. And so we never know when this document is going to be utilized. So we want to make sure that we stay consistent in the way that we record all of our data and all of our notes. And I think we mentioned this last time as well, but remember that you always want to put, our biochemical data on the left where we went through the labs, and you want to assess these labs and kind of make sure that you have them in your biochemical assessment. And then on the right for your anthropometric measurements, always include the birth date, the gestational age. And then when you're assessing, we have here the current. You'll always want to add your PMA, and you always want to add your percentiles and your Z-scores along with the actual weight, length, and head circumference. I believe in this one, we did not calculate the weight for length, but that is also given to you when you put it in the PD tools. So we did forget to put that in. Don't forget to put that in your ADIME, right, Dr. Abel?
Yeah, actually, you would use the Olson's BMI. There isn't a weight for length for the premature infant, not till you get to the CDC, WHO CDC. But Olson does have a BMI for these premature infants, and that would be important to put that in there.
Yes.
Because growing proportionate is very important.
Okay, so here we have the current, and then on here we have all our previous measurements along with our rate of weight gain that we already assessed as 6.5 grams per kilogram per day, which was very low compared to the goal rate of weight gain, which should be around 15 to 16 grams per kilogram per day. And so we also calculated our estimated PN and estimated EN calories and protein. And remember that this can also be assessed from all of the normative data that Dr. Abel provides us. There's different sources that we can use, like Espegan, Ziegler, and there was one more, AAP, right?
Yes, yes. Good job.
And guys, remember, I know this is always very confusing, but the actual intake is always going to be what this baby was actually taking in before we're making our recommendations. So we have to put in the amount that they were starting at. And then when we make our nutrition recommendation, that's going to be where we put in what we're recommending to change in the EN, PN, and oral intake and any type of supplements. Don't get that confused. Also, in our food and nutrition history, this is where you're going to put the actual PN and EN order that the babies were on and I went ahead and added because I thought it would be important, right, Dr. Able, to put the nutrition history of the fact that the lipid minimization strategy failed and when they started the SMOF lipids.
Absolutely, that's very important. Any details that are objective data like that would be important to include. Even if you go back, you know, I'm not going to mark you right or wrong on this, but even like when did they start the progesterone at 4.5? So even a date would be good. Or, you know, how you put the SMOF started May 16th. It is important as we're going through these very vulnerable times with these babies is to include dates, because as you start to assess them, those are questions you're going to be asking. Well, okay, how long were they at that rate, and how did they do? What was their ostomy output, or what was their stooling like? Very, very, very important questions.
Yeah, that's good. We have to remember that. We should put dates because that would be very helpful.
Yeah, but it's not an absolute. If you didn't put the dates, it would be okay. It's just a clearer picture.
Of course. Okay, and then we have our client history. This is the past medical history that we went over. So it's definitely important to make sure that you put all of the past medical history of, in our case, Brandon's scenario. So this is basically just making sure that you reference the actual scenario and make sure you, you know, put it accordingly in your ADIME note, especially with the dates as well. Okay, and then we have our PES statement. Remember that there are different PES statements that you could use in these types of scenarios. This is one that Nick and I chose that we thought would be the most relevant in Brandon's scenario. So we chose inadequate protein and energy intake related to the necrotizing enterocolitis, as evidenced by the really low rate of weight gain of 6.5 grams per kilogram per day for the last week, compared to the goal, which is supposed to be 15 to 16 grams per kilogram per day. But Dr. Abel, there are others that we can use, right?
Absolutely. So it depends, your nutrition diagnosis will depend on what your nutrition interventions will be. And you really want to pick the nutrition diagnosis that will have the greatest impact on the overall health of that baby. Yes. And just FYI for dietitians in general, you usually look at the intake first. That should be our primary focus as registered dietitians. That we have the most control of and the greatest skills, and the rest of the team is looking to you for that kind of advice.
Well, that's the whole point of our nutrition diagnosis, is that our nutrition diagnosis needs to be related to our nutrition intervention. So whatever we're recommending in our nutrition intervention needs to be what was addressed in our nutrition diagnosis, right?
Exactly. And even one step further, your monitoring and evaluation hopefully is going to show an improvement on that nutrition diagnosis. And that is how I do grade. I look at your nutrition diagnosis, your interventions, will they impact the nutrition diagnosis? And does your monitoring and evaluation state, you know, whether it improved or didn't improve?
And guys, I just want to reiterate that remember that this is an example scenario. Remember that in our actual assignment, the scenario will be different. So it will be, you know, there's going to be a lot of similarities, but at the same time, it's not just about copying exactly what Nick and I chose to put on this ADIME. Remember that we are students as well. We make mistakes as well. So do not justify trying to mimic exactly what Nick and I choose to do. Remember that you need to assess your own scenario and make sure that you are assessing it in a way where you're making that diagnosis and creating an intervention and monitoring and evaluation specific to that scenario. That's what we're doing for this scenario. That's what you should be doing for our actual assignment in the scenario. They're going to be different. Okay. Now we have our nutrition intervention. This one is definitely the most integrative that we've had so far, because Brandon is a complicated baby. So we have to put a lot of, I mean, Nick did so much math. And so we have to make sure that we record all of that. When you assess the nutrition, the PN and the EN, you can see that they're very similar. I believe if you calculate the percentages, it comes out to about the same. It comes out to 76% and 22% of enteral nutrition. But remember that because this baby has neck or had neck, we want to advance the feeds. And remember, this was in one of the first slides where we have 3 choices of advancement. So this is dependent on you as a registered dietitian and what you want to do. In our case, what we chose to do is kind of go very, very, very slowly and very, very, very gradual. What do you think, Dr. Abel? What should we do?
I often choose that. They're all going to be slow, but really
the slowest, I would say, because we're doing only 0.5 milliliters.
Half a milliliter an hour is not very much volume, and then you would only increase every other day. So you're not going to get very far very, very fast, that's for sure. But hopefully they're going to tolerate, and you're going to be able to keep advancing. You know, it's like the tortoise that, you know, goes gradually instead of the hare that runs real fast. You know, slow steps can get you to your goal.
Slow and steady.
So I just want to bring something up about that advancement, because we chose 0.5 milliliters per hour every other day, but another option, just to sake of argument, is 1 milliliter per hour twice weekly. So if we look at the 0.5 milliliters per hour every other day, that'll end up being, you know, over the span of 1 week, about 1.5 milliliters per hour, maybe 2. So is it more that it's slower, like 0.5, like slower each day, or like the fact that it's like weekly?
Well, the 1 meal twice a week, you're staying at the same volume for a longer period of time to watch for feeding intolerance. This one is more, it's not rapid, but you're systematically going every other day. So you're not really watching as long for the feeding intolerance. And that's really the biggest difference in what you're doing.
Okay. And okay, so that was our decision. We chose to do 0.5 milliliters per hour every other day. And then we put in our EN and PN recommendations. And then we want to make sure, I mean, some of this kind of you can tell that it kind of coincides with our monitoring and evaluation, right, Dr. Abel? Because it's like, you know, continue to monitor the direct bilirubin, but it's something that you just do constantly, right?
Right, because you really are going to want to monitor the labs for the parental nutrition. You're at 76%. Mm-hmm. You want to monitoring the feeding intolerance is huge, but you know, with the parental nutrition, we have concerns. We also have a baby that had part of their ileus removed, so monitoring for vitamin B12. Remember the first slide I showed you? That probably feels like a day ago, but it really was just 40 minutes ago. But very, very important, you know, and then looking at just, you know, how is the baby responding both to the parental nutrition, the lipid, and the enteral nutrition. Very, very important, because that's going to make a difference. And even back to the question about the advancement, you as the dietitian will be interacting with the nurses and getting to actually know the baby and what they're going to do. You might not go and talk to the nurse every day, but more than likely on these more complicated babies, you're going to find out what's actually happening with the baby. Stooling, output, all those kinds of things.
Okay, and then also in regards to when we recommend the supplements. So I know on the bottom we have the supplements with the actual recommendations that we got from the normative data of what we should be recommending for on a daily basis. Yeah, I did want to ask because I know what should we do for vitamin K? Because we did notice that the INR was low. Or I'm sorry, the INR was high. So
yes, you do have it right. One milligram.
We have vitamin K there. Okay.
But I did want to just mention this quickly with what you're going to be doing. We talked about this, but I just want to reiterate. You're going to, when you do this on your own, you're going to look at what is recommended to initially start. So For example, selenium, we start with 3 mics per kilo. Zinc, we start with 4 mics per kilo. Copper, we start with 20 mics per kilo. We assessed the labs, and that was why we decided to go to what we went with. So we went from 3 to 4 mics per kilo in the selenium because the selenium was low. We kept the zinc the same, and the copper, we went from 20 to 25 mics per kilo. And we also did the carnitine. And the vitamin K was, as Janine just talked about. So that's part of your assessment and why you're making these recommendations. So you might have recommendations on sodium, potassium, those things as well.
Yeah. When we look at the vitamin B12, do we supplement with vitamin B12 as well?
Vitamin B12 will be needed to be given intramuscularly with a shot. And so usually the physician will make that decision. You'll just remind the team that absorption is not happening because the ileus was removed or how much of it was removed. You know, if the whole thing wasn't removed, there might be some absorption, but it's of concern.
Got it. Okay, and then lastly, we have our monitoring and evaluation, which again is, you know, we already mentioned this in our intervention, but it's very important that that your monitoring and evaluation correlates with your intervention. So everything that you did in your intervention, you want to make sure that you're checking up on the next day with this baby to see how, you know, Brandon was doing. So feeding tolerance and stool output, like what is a normal stool range, like stool output range?
Probably a normal would be around 3 to 5. So 7 would be high. We would look more at, you know, is it liquid? You know, what color is it? You would actually assess the color of the stool. So there are some other things as well. Sometimes when these vulnerable babies and we're advancing, we call it's pushing through the feed. So even though we might see some things that we don't like, we might still keep increasing the volume because we have found that if we push through the feeds, they do okay. So, but that's why you have a whole medical team. You're not making all those decisions on your own.
Definitely. Okay. And then, so you're going to monitor the labs very closely, especially the ones where we can see whether or not our supplements are working. So like the vitamin K, we're going to monitor the INR. We're going to recheck the serum trace panel later on in a month, because I'm assuming it takes a little bit of time for that to kind of change in labs, right, Dr. Abel? Is that something that like...
Right, yeah. The parental nutrition is going to change pretty quickly. Enteral, it's going to take time. But the other thing with labs is you're draining the blood out of that baby. So we really do not want to take labs unless we absolutely need to take them. So, you know, taking them, depending where they are, but twice weekly, usually it's Monday, Thursday, is more than adequate.
Got it.
And your changes, like you just said, are not going to show up in the lab that quickly.
So basically the things that we definitely want to monitor on a daily basis are going to be the feeding tolerance, the stool output, the weight daily, and then the head circumference and length weekly, which is normally done like once a week, normally on Mondays. So that's going to be what we should be monitoring very closely. And then the labs check as soon as they're done, whenever they're done, right?
Yes, that's correct.
And then I think that's really pretty much it.
That's how we all feel, even as the teacher. This is a hard module.
This was a hard module, guys. Thank you for making it all the way through the end. Remember that Dr. Abel is always here for you. If you still have any questions or concerns, please email her. You can schedule a Zoom meeting with her. Remember that now we're having the live sessions with her on a weekly basis where you can have a live Q&A. And we hope this video helps you, and good luck, guys.
Yes, good luck. And next week will be very easy.
Yes.
You made it through the hardest part of the course.
Thank you, Nick, for being our math guru, and thank you for being our knowledge resource. You've been such a great help.
And thank you, Janine. You do a great job keeping us all cheerful and on track.
All right. Bye, guys.
Bye, everyone.
Bye-bye. Bye-bye.